Hello, I'm John Clymer, Executive Director of the National Forum for Heart Disease and Stroke Prevention. Welcome to this briefing on key takeaways from the 2026 Guideline on the Management of Dyslipidemia. Since all the organizations that contributed to the guideline are National Forum members, I want to give the correct title. The ACC, AHA, AACVPR, ABC, ACPM, ADA, AGS, APhA, ASPC, NLA, PCNA Guideline on Management of Dyslipidemia. We are pleased to have you with us for this important conversation about the newest gold standard science-based guidance for lipid management and cardiovascular risk reduction. Today's briefing features two experts who will help us better understand the 2026 guideline, what has changed since the last one, what these new changes mean for clinical practice and public health, and how we can move rapidly from recommendations to real-world implementation. Our speakers will provide an overview of the guideline, practical strategies for implementation, and we will have ample time for questions and discussion. Dyslipidemia remains one of the most significant and modifiable causes of cardiovascular disease. The release of this guideline gives clinicians, health systems, public health leaders, employers, community partners, and the most important stakeholders on the healthcare and public health team, patients, or as I prefer to call them, people, opportunities to strengthen prevention, personalize risk assessment, improve treatment, and close gaps in care. Today's briefing is presented by the National Forum's Value and Access Collaborative. We are grateful to the sponsors that support the collaborative and make it possible for us to convene briefings like this one, focused on evidence, implementation, and improved cardiovascular, metabolic, renal, and mental health. These sponsors include Ardelyx, AstraZeneca, the Bristol-Myers Squibb-Pfizer Alliance, Novartis, and Regeneron. We encourage you to use the chat function to say hello, offer comments, and engage throughout the meeting. We will also be sharing helpful links and resources in the chat. Please submit your questions using the Q&A button at the bottom of your Zoom screen. Later in the program, we'll have an open forum and live Q&A. We encourage you to share your questions, examples, and implementation challenges. We also want to hear from participants who may already be working on implementation, education, access, or local initiatives related to lipid management and cardiovascular risk reduction. If you have a brief example, resource, or best practice to share, please note that in the Q&A box. Our team may promote a few participants to speak as time allows. I want to begin with a brief participatory exercise. I want to take a quick pulse check here. A poll will appear on your screen. In fact, it's there now, asking how you would rate your current pre-briefing understanding of the 2026 Dyslipidemia Guideline. I understand it's only been out for a little over 60 days. Please take a moment to respond. I'll ask the same question again at the end of today's briefing to see how your understanding of the guideline has changed.
All right, we'll give just a few more moments for the poll. Great response rate, and here we go with the results.
All right, we have a very good range of knowledge of the guideline, from no knowledge to moderate understanding. Thank you for participating in the poll. Now, before we move into the presentations, I want to recognize the significant work that goes into developing national clinical guidelines. These recommendations reflect a rigorous process, careful review of the evidence, and collaboration across multiple professional organizations, as the official name of the guideline attests. The product of these prodigious efforts is a roadmap for improving cardiovascular health and cardiometabolic health and reducing risk across the lifespan. We are fortunate today to have two outstanding presenters with us, both of whom were on the Guideline Writing Committee. First, we will hear from Dr. Ijeoma Isiadinso, Associate Professor of Medicine in the Division of Cardiology and Medical Director of the Emory Center for Heart Disease Prevention. Dr. Isiadinso will provide an overview of the 2026 guideline on the management of dyslipidemia, including key updates in evaluation, treatment, risk assessment, and special populations. Then we'll hear from Dr. Anne-Marie Navarre, Associate Professor of Medicine and Cardiology at UT Southwestern Medical School. Dr. Navarre will focus on putting the guideline into action, including implementation challenges, patient concerns, clinical opportunities, community and employer-based strategies, and policy changes needed to support adoption. Together, they will help us understand not only what's in the guideline, but how we can use it to improve care and outcomes. With that, it's my pleasure to welcome our first presenter, Dr. Ijeoma Isiadinso. I will now turn it over to you, Dr. Isiadinso.
Thank you very much, John. It's such a pleasure to join you and Dr. Navarre here to talk about our guideline and some of the important findings that we wanted to share and recommendations. This really is a great opportunity to share with everyone the direction we have taken with the guideline and really how it can help improve cardiovascular risk for our patients and help inform on cardiovascular risk and treatment goals. All right, so my slides should be on the screen now. Is that correct?
That is correct.
Wonderful. So as I said, I'm going to start by just talking a little bit about some of the key takeaways from the 2026 ACC/AHA guideline on the management of dyslipidemia. As John mentioned, I'm going to talk a little bit about some of the differences between the 2018 document and our current document. So I'd like to first start by saying, why did we do it? Well, it was time. It was time to update the guideline. There are several cardiovascular outcome trials like the Odyssey Outcomes, the Fourier trial, Orion trials as well, since the 2018 document that have informed us on newer pharmacotherapies that are useful in reducing cardiovascular risk. And so we wanted to talk about some of those medications and treatment goals and inform our audience on which ones to use in which patient populations. The second thing I wanted to highlight, there's a change in terminology. The 2018 document was entitled The Management of Cholesterol. The current document is The Management of Dyslipidemia, and that was intentional because we wanted to highlight that we are focusing not just on treating high blood cholesterol, but other lipoprotein particles that impact cardiovascular risk. So we talked a little bit about elevated lipoprotein A, when to screen, and how to treat individuals who have elevated lipoprotein A, and also the management of hypertriglyceridemia. We also returned to using treatment goals, specifically LDL cholesterol and non-HDL, and talked about when one should be testing for ApoB and how it also informs about residual risk. Again, it addresses implementation of newer pharmacotherapies that reduce atherogenic lipoproteins. And then we wanted, of course, to include in this document the use of our newer risk assessment tool, the Prevent ASCVD. As John mentioned, one of our greatest concerns when it comes to cardiovascular risk is not the absolute LDL cholesterol, but it's the lifetime exposure to high levels of LDL cholesterol that actually confers to cardiovascular risk. And you can see that the earlier that you are able to intervene, you can actually change the trajectory of one's life course and reduce their risk of developing cardiovascular disease and prevent cardiovascular events. And so the lower the LDL cholesterol level, the lower the risk of cardiovascular disease. So the first thing that we wanted to highlight is that we need to start early when it comes to screening for dyslipidemia in adults as well as in children. And so in adults, we need to begin testing for dyslipidemia by checking a lipid profile at the age of 19. We need to do that every 5 years, but more frequent screening if the individual has additional cardiovascular risk factors. Children need to be screened at age 9, between ages 9 to 11, because we want to make sure we're capturing those who may have significant genetic lipid disorders like familial hypercholesterolemia. It's important because we know that children between the ages of 8 to 10 can have evidence of subclinical atherosclerosis on CIMT that early, and that actually can increase their risk of developing atherosclerosis in early adulthood if they are not treated. So it's important that we're screening children. And then if there's a family history for premature ASCVD or FH, then we need to start screening as early as age 2. I do want to remind everyone that the foundation of management of dyslipidemia is lifestyle modification. We highlight here the Life's Essential 8, and following these recommendations for a heart-healthy diet, physical activity, maintaining an ideal weight, blood sugar, cholesterol, and blood pressure are really important along with adequate sleep and avoiding nicotine use in really reducing one's risk for ASCVD, but also are the first step in treating dyslipidemia. So we need to be focusing on lifestyle modification. And it's important that our patients understand that we're not immediately always jumping to medications, but you may need a medication, but we are also going to continue to talk to you about lifestyle things that you can do that can also reduce your risk and lower your lipoproteins. So in addition to screening, one thing that we are also recommending is measurement of lipoproteins, both total cholesterol, LDL, HDL, but also reporting of non-HDL in adults and children. You can't treat what you don't know. You don't know an individual's risk if you don't know what their lipid panel is. Our recommendation is that non-fasting or fasting lipid profile are both equally efficient in identifying an individual's ASCVD risk and can provide guidance on the initiation of lipid-lowering therapy. And that's because there really isn't a lot of variability in LDL cholesterol levels between non-fasting and fasting lipid profiles. Now, there is a population where there is a difference, and those are individuals who have a family history of dyslipidemia, if there's premature ASCVD, or if they're individuals who have high triglyceride levels. So these individuals really do need a fasting lipid profile because the lipid profile in the non-fasting state may not accurately estimate the LDL cholesterol level. Advanced lipoprotein testing is not recommended for routine use for assessing ASCVD risk because it really doesn't provide any additional information specifically for the initiation of lipid-lowering therapy above and beyond what your regular lipid panel will provide. So once you've identified an individual has dyslipidemia, the next step is to have a really comprehensive discussion about the benefit and risk of lifestyle modifications, lipid-lowering therapy, and additional evaluation that may benefit and inform on cardiovascular risk with your patient. So the discussion, as I said, is very comprehensive. You talk to the patient first and foremost about what their ASCVD risk is. That's your starting point. You consider additional evaluation, looking at risk enhancers or calcium scoring, which I'll get into shortly. But again, we highlight at that time, during that discussion, the importance of lifestyle modification in risk reduction and management of dyslipidemia. We talk to the patient about what the expected benefits are with each treatment recommendation that we make, whether it's lifestyle or different lipid-lowering therapies, so they can understand how that reduces their risk. We then invite the patients into that discussion to share with us what some of their concerns are, what barriers they may envision with adherence to lipid-lowering therapy. We know adherence is poor when it comes to statin therapy for patients who are certainly at benefit of receiving lipid-lowering therapy. We also want to hear about costs and talk about drug-drug interactions. So once we've done that, the next step is to estimate the individual's ASCVD risk. And this is where our new risk calculator comes in, the Prevent ASCVD Risk. This should be used for estimating cardiovascular ASCVD risk in individuals who do not have ASCVD or subclinical atherosclerosis, and they have an LDL cholesterol between 70 and 189. Compared to the pool cohort equation, the Prevent ASCVD Risk calculator provides more accurate ASCVD risk estimation compared to the pool cohort. And in fact, it estimates risk lower at about 40 to 50% compared to the pool cohort equation, because the pool cohort equation actually was overestimating risk in certain populations. It is a very accurate and reliable risk calculator because it was established in 3.3 million individuals and externally validated in 3 million individuals, a much larger population compared to the less than 500,000 individuals that were used to establish the pool cohort equation. Here you see the risk categories for Prevent ASCVD. So those who have a 10-year ACVD risk less than 3% are considered to be at low risk. Those who have a 10-year ACVD risk between 3 to 4.9% are borderline, 5 to 9.9 are intermediate, and those who are above 10% are considered to be at high risk. And the key thing is, although we lowered this cutoff for the risk categories, it actually does not translate to a greater number of individuals who end up requiring a lipid-lowering therapy. So we are not over-treating individuals based on these risk categories. Once you've identified their 10-year ASCVD risk, the other thing to consider is whether there are other risk enhancers that may also impact their overall cardiovascular risk. I've listed them here, including family history of first-degree relatives who may have premature ASCVD, certain risk ancestries that are associated with higher ASCVD risk, chronic inflammatory diseases. We know that those with systemic lupus, rheumatoid arthritis, or advanced psoriasis actually have premature and accelerated atherosclerosis, which puts them at greater cardiovascular risk. CKM syndrome, and then reproductive risk markers, which I'll talk about a little bit as well. So it is important that we are looking at beyond just the calculated 10-year risk, but whether or not additional risk enhancers will up-risk stratify our patients into a higher risk category. So we recommend the CPR framework. You start by first calculating the 10-year ASCVD risk, and you classify the individual into the appropriate risk category. And then you personalize their ASCVD risk by using risk enhancers. You can also then, depending on the patient, whether or not there's clinical uncertainty or whether or not the patient themselves is unsure whether they would like to proceed with a recommendation for lipid-lowering therapy, use a calcium score. That is applicable for individuals who are borderline to intermediate ASCVD risk because it can help further refine their risk category. And then based on that, you reassess your treatment recommendations, and then you can move forward with either just lifestyle modification or lifestyle and lipid-lowering therapy if the individual is in a borderline to high risk of ASCVD. So when should we consider using coronary artery calcium scoring? We recommend it in men above the age of 40 and women who are 45 or higher, because that can improve risk assessment and guide those LDL cholesterol and non-HDL cholesterol goals that I'll be talking to you about. It is important that when we look at these calcium scores, we're not looking at just the absolute CAC score, but we're also looking at the percentile, because both of these have prognostic importance and can be used to help risk classify your patient. This is data from a study published in 2023 that looked at CAC categories and the event rates for major adverse cardiovascular events. And you can see here that with increasing CAC score, there was higher likelihood of MACE events. But more importantly, for those who had a CAC score greater than 300, their MACE event was similar to somebody who had actually already had clinical ASCVD. So these individuals are at significantly high risk. And then that informs us about what to do for them when we identify their CAC score and know what their risk is. The next thing I wanted to talk about is lipoprotein A. Lipoprotein A, we know, is an independent causal risk factor for ASCVD and aortic stenosis. It is a genetically predetermined risk factor. It is not uncommon at all. It occurs in 1 in 5 individuals, which translates to 1.4 billion individuals globally. It doesn't require fasting, so you can do this on a non-fasting sample. And the most important thing is because it is genetically predetermined, you really only need to check it once in an individual's lifetime, except in unique circumstances, like if it was initially checked in an acute inflammatory state, or if it was checked when a woman was transitioning into menopause and maybe she had a borderline lipoprotein A level. Some of the benefits of lipoprotein A testing is that it can help predict and reclassify an individual's risk for CVD. It is actually really important in cascade screening. So if you identify that an individual has lipoprotein A, it actually provides you with an opportunity to make recommendations to that individual's family members to undergo screening because of its genetic inheritance. And it allows you to identify individuals who are at high residual cardiovascular risk. If the LDL is well controlled, but their lipoprotein A is high, you want to be even more aggressive about managing known cardiovascular risk factors. So the recommendations in the 2026 dyslipidemia guideline is that we screen all individuals at least once in their lifetime for lipoprotein A. And then for those who have a history of familial hypercholesterolemia, premature ASCVD, or personal history of hyperlipoprotein A, that we are making sure that we're recommending cascade screening of first-degree relatives. The other thing I wanted to highlight here is that lipoprotein A levels are not all equal. And so just because someone has elevated lipoprotein A, their risk can be high depending on what their actual level is. Those who have lipoprotein A levels of 125 nanomoles per liter or greater than 50 milligrams per deciliter have a 40% greater risk, relative risk of ASCVD. And as you can see, as the lipoprotein A level increases, the ASCVD risk increases even more significantly. So we need to make sure that we are targeting our therapies and our risk reduction efforts based on those lipoprotein A levels. Apolipoprotein A is another lipoprotein that we now included in this particular guideline, specifically because it allows us to be able to understand an individual's residual cardiovascular risk. We know ApoB is a more accurate reflection of atherogenic particle burden compared to LDL cholesterol because it actually measures the number of atherogenic lipoproteins that an individual has. So in the figure off to the top right that you see here, these are two individuals who both have LDL cholesterol levels of about 100, but the individual at the right has a higher ApoB concentration. And this individual is at higher cardiovascular risk compared to the individual lower ApoB because they have higher ApoB levels. So the recommendations in our guideline are that for individuals who are already on lipid-lowering therapy, particularly those who are more likely to have residual risks such as ASCVD, they have type 2 diabetes or elevated triglycerides, that we are measuring ApoB in order to help us better understand their cardiovascular risk and intensify treatment and target ApoB, especially after you have already achieved the LDL cholesterol and non-HDL goals. So the key thing is that for these individuals, we are focusing first and foremost on targeting LDL goals and non-HDL goals, and then you can check the ApoB levels. Pregnancy is a unique time in an individual's life where we can actually glean some information about their cardiovascular risk. Adverse pregnancy outcomes occur in about 10 to 20% of all pregnancies, and they can be associated with increased risk for cardiovascular disease. I included this slide on the right because I wanted to share with you that not only do some of these some of these risk factors results in an increased risk for cardiovascular disease, but they actually increase risk for stroke and diabetes depending on the risk factors. So preeclampsia and eclampsia is associated with increased risk for cardiovascular disease, but also an increased risk for hypertension and heart failure later on in life. We know that gestational diabetes is associated with an increased risk for diabetes, but also increased risk for ischemic heart disease. And in preterm birth and small gestational age are also associated with an increased risk for cardiovascular disease. So what does this mean? It means that when we are interacting with our patients, that we need to be asking about their pregnancy history so that we can better understand their risk for ASCVD. But we also need to be educating our patients to share with all their clinicians, not just their obstetrician or their gynecologist, about their pregnancy history so that all the clinicians that they're interacting with can be aggressive with risk factor modification, but so that the patient themselves becomes educated about their risk for cardiovascular disease. Familial hypercholesterolemia is another common genetic disorder that is associated with increased risk for cardiovascular disease. Heterozygous FH occurs in 1 in 250 individuals and is associated with a significantly higher risk for cardiovascular disease compared to those who do not have heterozygous FH. The key thing here is that we do not recommend the use of risk assessment tools in estimating the risk for cardiovascular disease in these individuals who have heterozygous FH, specifically because they are already at high risk for ASCVD. So these individuals need to really be treated aggressively to lower their cardiovascular risk. The risk assessment tools that we currently use were not really developed in individuals who had heterozygous FH. Were really developed in the general population and truly should not be used in this patient population to best understand their risk. Genetic testing was another one of our recommendations in the current guideline. And that's because we know that individuals who have even moderate LDL levels, that if they are identified as having a genetic variant for FH, that they are at even higher ASCVD risk compared to those who do not have a genetic variant for FH. And so for those who have probable or definite FH based on your clinical assessment, those individuals should undergo genetic testing. So what are our treatment recommendations? So once you've done the risk assessment, you may have used a calcium score to help you reclassify the individual's risk, and now you're ready to share with them what the recommendations are to help reduce their risk and to manage their dyslipidemia. For the primary prevention of ASCVD, for those who are low risk, less than 3%, we recommend focusing on lifestyle modification if the LDL cholesterol is less than 160. For those who have an LDL between 160 to 189, then we recommend a moderate intensity statin to target an LDL cholesterol level below 100 or a non-HDL less than 130. And these targets are easy to remember because the non-HDL target is always going to be 30 milligrams per deciliter greater than the LDL target. For those who are at borderline risk, we recommend a moderate intensity statin. And for those who are at intermediate risk, then we recommend a moderate to high intensity statin for the same target LDL or non-HDL goals. Now, for those who are at high 10-year ASCVD, now we recommend high intensity statin because you really want to get that LDL cholesterol below 70 and the non-HDL below 100, and really targeting a robust LDL reduction by greater than 50%. If with your high intensity statin, the patient's LDL and non-HDL goals are not met, then you want to think about adding additional therapy, adding ezetimibe or a PCSK9 inhibitor or bempedoic acid. We recommend repeating lipid panels at the initiation of within 4 to 6 weeks of initiation of lipid lowering therapy, because we want to really make sure we eliminate clinical inertia and avoid starting therapies and not checking lipid panels for another year or so. Calcium scoring, as I mentioned, can help you inform risk, and it can actually help you guide lipid lowering therapy. So for those who have a calcium score of 100 to 999, we really want to target LDL lowering therapies that will achieve an LDL cholesterol level below 70 or a non-HDL below 100. And then once you've achieved that, you can try to focus on their ApoB. Now, that is an optional goal to achieve an ApoB goal less than 70 if you've achieved your LDL and non-HDL goal. Now, if they have extensive coronary calcification above 1,000, now you want to be very aggressive and target an LDL cholesterol less than 55, similar to those who have clinical ASCVD, and a non-HDL less than 85. We also recommend using other CT scans that weren't specifically targeted for looking at subclinical atherosclerosis. So I often do this in my practice. If a patient had a lung scan, I will look at the CT to see if there is any evidence of coronary artery calcification. And if I do see that there, then I discuss with the patient that they already have evidence of atherosclerosis. And then we talk about the use of moderate or high intensity statins, and we talk about their LDL targets based on our findings. For those who have severe hypercholesterolemia, we want to be aggressive. First of all, ruling out any secondary causes for high LDL. And then, of course, we talked about cascade screening. And then we want to initiate maximally tolerated statin because we want to achieve an LDL cholesterol lowering of at least 50%. For those who do not have clinical ASCVD, but they have a genetic or clinical suspicion for heterozygous FH, or they have additional ASCVD risk factors or presence of subclinical atherosclerosis, then we want to be aggressive and add additional lipid-lowering therapies to a target LDL lowering below 70 and a non-HDL below 100. For those who cannot either afford a PCSK9 inhibitor, have side effects, or cannot get access to PCSK9 monoclonal antibody, inclisiran is another agent that can be considered. For those who have clinical ASCVD, we target a much lower LDL cholesterol less than 55 or a non-HDL cholesterol less than 85. For diabetics without ASCVD, we recommend a moderate intensity statin for a target LDL less than 100. And then for those who have multiple ASCVD risk factors, we're a bit more aggressive in our recommendations and recommend LDL cholesterol less than 70 with the use of a high intensity statin. It is important to identify those who are at very high risk versus those who are at high risk. For those who are at very high risk, they have more than one major ASCVD event, an ischemic stroke, myocardial infarction, peripheral arterial disease. And then for those who have high-risk conditions, if you've had more than one major ASCVD event and more than two high-risk conditions, then those are considered at very high risk. And as you can tell, most individuals are probably going to fall, most individuals who we interact with on a day-to-day basis are probably going to end up in the very high risk category. It doesn't take much for you to have somebody who may have had a prior MI and they're over the age of 65 and maybe they have diabetes. That individual is at very high risk. And so our recommendations are for those who are at very high risk for secondary prevention, that we start a high intensity or the maximal tolerated statin, and then with a goal LDL reduction of more than 50% for a target LDL less than 55 or less than 85. And then optional target of an ApoB less than 55. So similar to the LDL cholesterol target in these very high-risk individuals. And then we want to ensure that we are recommending the addition of other lipid-lowering therapies for those who do not achieve their LDL and non-HDL targets if they are adherent to therapy. And that includes ezetimibe, PCSK9 inhibitor monoclonal antibodies, and in certain instances, inclisiran or bempedoic acid. For those who are not at very high risk, the target LDL cholesterol is less than 17 and non-HDL less than 100. And again, using additional lipid-lowering therapies if they're not at goal. I talked about adverse pregnancy outcomes. One of the things that I wanted to highlight is that certainly that we do have certain things to consider about the management of dyslipidemia during pregnancy and in the use of lipid-lowering therapies in individuals who are of childbearing age. And so for most individuals who are of childbearing age who have hypercholesterolemia, but they're not at high risk for ASCVD, if they are planning to become pregnant, we would recommend stopping statin therapy 1 to 2 months before they attempt to become pregnant. In my practice, I usually just tell the patients that once you start planning or you're thinking that you're going to start trying to become pregnant, then we need to go ahead and stop your statin. For pregnant individuals who have a severe hypertriglyceridemia with triglyceride levels above 500, our concern is avoiding pancreatitis. And so after the first trimester, we would recommend the use of fibrates or the use of high-dose omega-3 ethyl esters to lower triglycerides and reduce the risk of pancreatitis. Now, there are certain patient populations where we would consider the use of statin therapy, and those include individuals who are at high risk, so those who have FH or a history of clinical ASCVD. But this is really on an individual basis with the review of the benefit risk discussion with the patient about the benefit risk of continuing statin therapy and their comfort level with that. So this slide summarizes the lipoprotein goals for ASCVD risk reduction, primary prevention, LDL cholesterol less than 100 or less than 130. For those who have a prevent ASCVD risk less than 10%, those greater than 10% targeting an LDL less than 70 and a non-HDL less than 100. Severe hypercholesterolemia, we've talked about that as well. Clinical ASCVD, for those who are not at very high risk, we're targeting LDL less than 7 and non-HDL less than 100. For those at very high risk, an LDL less than 55 and a non-HDL less than 85. We talked about diabetics as well, LDL less than 100 or non-HDL less than 130 if they don't have any ASCVD risk factors. And then if they have subclinical atherosclerosis, then their target is less than 70 to less than 100 if the CAC score is between 100 to 999. But if it's above 1,000, targeting a much lower LDL cholesterol and non-HDL. So the goal here with these current guideline, our current guideline is first and foremost, as I said, screening much earlier. We want to lower the risk for cardiovascular disease across an individual's lifetime, intervening early with lifestyle modification and starting lipid-lowering therapies early when indicated, making sure that we're checking lipids appropriately, aiming for our target LDL and non-HDLs as already reviewed, and checking a lipid panel 4 to 12 weeks after you either start or change lipid-lowering therapies, and then 6 to 12 months after once they're on stable therapies. So with that, I'll stop and turn it over back to John.
Thank you, Dr. Isiadinso. Really appreciate your groundiness in the major updates and the significance of this guideline. I'm now pleased to welcome Dr. Anne-Marie Navarre, who will help us move from guideline awareness and understanding to implementation. Dr. Navarre, the virtual floor is yours.
Great. Well, thank you to John, and thank you for all of you for attending. Let's see. Make sure this works. Everybody sees my slides okay?
Yes.
Great. So my name's Anne-Marie Navarre. I was pleased to be part of the guideline committee. I'm a preventive cardiologist at UT Southwestern, and my goal of my talk today is to talk a little bit about some of the challenges that we're going to have in putting the guideline into action. What we put forward is an evidence-based guideline that we think, based on the totality of evidence, if we implemented for all eligible patients, could really start to bend the curve on the leading cause of death in the United States, which is ischemic heart disease. But we've got some work to do, and we have some major barriers to overcome. So just a quick reminder how much evidence we have behind lipid-lowering therapy, especially for statins. We have dozens of cardiovascular outcomes trials for statins that show pretty consistently for about every 40 points we lower somebody's LDL cholesterol, we cut their risk of a cardiovascular event down by at least 25%. But in spite of having statins around for nearly 3 decades, we have major gaps in utilization of statins. In people at high risk for heart disease, about 1 in 3 is on no statin. And when we looked 10 years ago, only about a quarter of those individuals were on a high-intensity statin. And updated evaluations of this has shown very little change since that analysis from 10 years ago. Even in those at the highest risk of cardiovascular events, those who've had a prior heart attack or stroke, only about 40% are on a guideline recommended statin intensity. And under the prior guideline recommendation of an LDL goal of 70, only about 1 in 4 were reaching that target. We now recommend for the vast majority of patients with ASCVD, an LDL goal less than 55. But as of 2 years ago, only 12% of people with ASCVD were reaching that goal. So what's going on? Why are statins so underutilized? Well, a major issue that we face is the proliferation of misinformation and disinformation around safety of statins, as well as even the need for LDL cholesterol lowering. And this is available on the internet, on blog posts, in books, in documentaries, and it's now being proliferated on Twitter and other social media sites as well. And we've known for many years that amongst people who are offered a statin and decline, it's fear of side effects that is driving the majority of people to say that they don't want a statin amongst those who have been offered and choose not to. So just a quick level set, what's the actual truth about statins? Well, it's not in this book. It actually comes from clinical trials. We've done 22 randomized trials of statins with over 1,000 patients compared to placebo. In those studies, we enrolled almost 130,000 patients and followed them for 4 years. And just a reminder, in these trials, people don't know if they're on a placebo or a statin. And when we look across all of these trials, we have almost identical percents of people who discontinue a statin due to a side effect as who discontinue a placebo. So when people don't know what they're on, they're as likely to tolerate a statin as they are a placebo. So what's going on? Why in clinical practice do we have such high rates of discontinuation with between 30 and 50% of people stopping a statin after initiating? Well, one of the things that we think is going on is something that we call the nocebo effect. And this was actually a great article in the New Yorker by Gareth Cook in 2013 about the nocebo effect, which is basically the inverse of a placebo effect, where if you're afraid of a potential side effect, you're more likely to feel it. Now, for people who have this, it's very real, but it's just not a biological cause from the statin. It's our mind playing tricks on us because of how much bad information there is about statins out there. Now, how do we know that it's the nocebo effect? Well, we've actually done some really clever trials to try to get at what percent of people truly cannot tolerate a statin. And one of my favorite trials of this was the GAUSS-3 trial. Now, GAUSS-3 was a trial that was actually designed to test a new injectable cholesterol-lowering medication called evolocumab. It's also known as Repatha, brand name. And what the investigators were trying to do was find people who were truly statin intolerant, really could not tolerate it. And so what they did is they got a group of people who had tried and been unable to take at least 2 statins in the past. And then they randomized them to either get statin first and then a placebo, or placebo first and then a statin. And then they asked, do you have side effects? And people didn't know if they got placebo first or a statin because the pills looked identical. And here's what they found. In 250 people who got placebo first and then atorvastatin, about 1 in 3 had symptoms with atorvastatin but not placebo. About 1 in 3 had symptoms with placebo but not atorvastatin. 11% had symptoms with both. 15% had symptoms with neither. And about 5% quit after the first round. So it sort of shows that even in people who have tried and been unable to tolerate a statin in the real world, when they don't know what they're taking, it actually looks the same as a placebo. And we've studied the rate of actual myopathy, meaning muscle damage, or myalgia, meaning muscle pain, in clinical trials when we give people statins and placebo. And what we find is that about 1 in 10,000, certainly far fewer than 1 in 1,000 people, actually have muscle aches with lab-based evidence of muscle damage. And it's even rarer, more about 1 in 30,000 that have true muscle breakdown that can affect the kidneys. That's called rhabdomyolysis. And importantly, it's not subtle and it goes away when we stop the statin. Myalgias, which is just muscle aches without any evidence of muscle breakdown, does happen in about 1 in 3 people who are given a statin. But in the heart protection study, we found that 1 in 3 people who had a placebo also had myalgias. So what we think happens is that when people start a statin, they're just much more likely to attribute the regular aches and pains of living day to day to their statin than maybe they didn't carry the groceries right, or maybe they're not sitting appropriately in their chair. Because it's pretty clear from clinical trials that the amount of muscle aches that people get on a statin are about the same as placebo. And we've seen that for other statins as well: pravastatin, atorvastatin, lovastatin, really similar tolerability. So what do we do about this? Well, I think a key thing that we need to do is a better job at fighting misinformation about statins. This flyer saying fight information actually comes from a great Canadian lawyer, Tim Caulfield, who has put together some really useful guides to how to fight information. That starts with us not fueling or spreading misinformation on the internet, doing a better job at crafting messaging to counter and debunk information, and also supporting regulatory responses. So often, misinformation about statins is promoted by people who are trying to sell something else, and frequently that's some sort of a natural supplement or alternative. And in fact, there are numerous supplements that are marketed to protect the heart or lower cardiovascular risk. Technically, they're kind of going outside of what is allowable by FDA and FTC regulations. Now, we've made progress. In the last several years, both the FDA and FTC have started to crack down on misinformation and false advertising of supplements that people often use instead of a statin because they think that they may be safer. I hope that we see continued crackdown of this, because as people are marketed statin alternatives in the form of supplements and pills, it's often packaged with misinformation about statin safety. But speaking of myths, is it really misinformation that's leading us to not treat patients with statins? Or does it just feel that way because these are the most frustrating cases that we see in clinic? Well, we actually studied this in the PALM registry, where we had over 7,500 patients who were seen in cardiology, primary care, and endocrinology practices. And we asked them, if you were supposed to be on a statin but not, why? And while it is true that amongst people who had declined a statin, fear of side effects was the leading reason why people had declined therapy in the first place. In fact, the leading reason why people were not on a statin that should be was because they had never been offered one by their doctor. So while we spend a lot of time worrying about people declining statins or who don't want to be on cholesterol-lowering therapy, we actually found that if we did a better job at just identifying those who were eligible and offering them treatment, we would probably do a lot more than if we erased all of the misinformation in the first place. And notably, the vast majority of these people who declined a statin said they would be absolutely willing to try one if they were offered one by their doctor. So what's keeping us in clinical practice from identifying the people who need to be on lipid-lowering therapy? And there's a number of challenges. The first is just operationally. We ask a lot of our primary care doctors. In a 20-minute visit, you're supposed to be doing cancer screening, immunizations, cardiovascular prevention, hypertension, lipidemia, lifestyle, not to mention addressing all of the patient's concerns and whatever they need, doing refills, et cetera, et cetera. Also, while the guidelines are great and almost sort of an encyclopedia of evidence, they're really long and now quite complex, We have algorithms to fit all sorts of different patient populations, patients with coronary calcium, patients with different 10-year risks, patients who are statin intolerant, patients who are not a goal on statin therapy. And then on top of that, we've got multiple options of different choices to use. Meanwhile, clinicians are trying to find all of the different information in the EHR. Did you have a CT scan 5 years ago that had coronary calcium? Did you have a CAC score done at an outside institution? What's your last lipid profile? It's really hard to synthesize all of this in a really short time period. Meanwhile, it takes time to do the shared decision-making and complex education that we need to do. And if we put this into the context of what's actually happening in primary care, where we're seeing increasing burnout of our most valuable colleagues, who also happen to be some of the least well-paid of our clinician colleagues, you put this together, and I think it's just sort of unfair of us to expect our primary care colleagues to shoulder all of the burden to implement these guidelines. And the reality is, over half of US adults are now recommended for at least a discussion around lipid-lowering therapy. So we have to think about solutions to be able to offload this from primary care. And here's where I actually have some hope for using AI-based approaches. So AI is never going to replace a clinician, but it can certainly do a lot of the work that we're expecting clinicians to do so that we can use their time more wisely. AI is better at synthesizing patient records more quickly. It can synthesize guidelines with patient information to summarize where of those 100-page guidelines is most relevant for the clinician in front of them. It can provide personalized treatment recommendations. And now we're seeing emerging use of chatbot and other AI-generated educational information that may help us overcome patient-specific fears around statins. We can also start to automate some of the things that previously we often forget to do, like order the follow-up lipid panel or suggest what the next treatment step will be. And we have other interventions that we know can actually help improve uptake of statins and lipid management. Polypills or combination therapies work very well. The fewer drugs that people take, the more likely they are to stay on them. Pharmacist-based interventions are almost 100% effective when tested in clinical practice. They're really good at getting patients on therapy if we can actually just get them to pharmacists and do pharmacist-led interventions. So are more automated pathways. And the key thing about all of these types of interventions is that it's taking the burden off of the physician or the advanced practice provider and trying to move it to more of a team-based approach so that we have more hands on deck to help address really this epidemic of cardiovascular disease that we have. Here's a great example from the Brigham, which actually used trained community health, trained patient navigators. So these were not pharmacists or nurses, but just volunteers that helped reach out to patients, address concerns, help manage refills, follow up lab testing. And this program showed really impressive improvements, not only in cholesterol, but other risk factors like blood pressure. The challenge is that we don't have a reimbursement model to be able to scale these programs nationally. So often what happens is we have limited funds. We show that a pharmacist-based program works, but then we're not able to replicate this or scale it to other health systems because of the resource intensiveness. And this is where I think AI may help automate some of these higher touch programs in order for us to have more scalable and generalizable solutions. But it's not just statins that we need to increase uptake of. Many patients are unable to take statins. Even those who are on statins may have variable responses in terms of their cholesterol lowering. And we know that higher risk patients need LDL cholesterols below 70, if not less than 55 milligrams per deciliter. And in modeling studies, we found that up to 50% of patients with cardiovascular disease are going to need more than just a statin in order to get to goals. Now, we have a number of additional therapies beyond statins that we can use to get patients to goals. One of the most potent class of medications are injectable PCSK9 inhibitors. That's evolocumab and alirocumab. Those came out about a decade ago, and they were game changers potentially for LDL lowering. With an every other week shot, we were seeing LDL cholesterol reductions of over 60%. But what happened is when they first came out, they were nearly impossible for us to prescribe to patients. We did an analysis of several years of the initial experience of PCSK9 inhibitors nationally and found that over 80% were rejected on the first try. And even after going through a complex appeals process, fewer than half of patients ever were able to get insurance approval for it. Now, one of the challenges is that these drugs came with a very high sticker price, initially thousands of dollars a year. And because of that, we also ended up having patients with really high out-of-pocket costs. People were often paying 20% or more of an $8,000 a year sticker price. And that became somewhat unaffordable for many patients. So we looked and found that even amongst patients who got approval, about 30% or 40% were not picking it up from the pharmacy. And it was because of the high sticker price. This orange bars show amongst patients who got it approved what their out-of-pocket cost was. And in blue was the percent of patients at that out-of-pocket cost that were able to afford and pick up the drug from the pharmacy. And up to about $20 a month, we saw 90+% of patients filling it. But starting at $20 a month, increasing copays were associated with a dramatic reduction in whether or not people were actually filling the prescription at the pharmacy. And so it's very clear that this is not only a barrier to access, it's also worsening disparities because those who have the least resources and perhaps the greatest health challenges were the least likely to be able to afford therapy even when it was approved. We also found that out-of-pocket cost was the leading cause of discontinuation of therapy even after people got on drug in the first place. So we had issues with access and we had issues with cost. Now, fortunately, we've seen that come down substantially. The sticker price for PCSK9 inhibitors is down over 50% from the initial sticker price. And payer barriers have become a lot easier to navigate. Approval rates are now well over 80% for people prescribed PCSK9 inhibitors. But uptake of PCSK9s remains quite low. We looked through 2021 at the percent of individuals with ASCVD who were on a PCSK9 inhibitor. Now, remember, I told you that probably over 50% of people are going to need something beyond a statin to get to goal. And what we found was as of 2021, only about 2% of people were on a PCSK9 inhibitor. And while we all, as doctors, like to blame someone else for not reaching goals, we probably needed to do a better job of shining the spotlight on ourselves. So recently, we analyzed what percent of prescribers were actually using these therapies at all. And the data were sobering. We found that only about half of cardiologists, as of the end of 2022, had ever prescribed a PCSK9 inhibitor monoclonal antibody. And when we looked at primary care doctors, it was fewer than 5%. So these are powerful drugs. Access has improved, out-of-pocket costs have gone down, but they have yet to be integrated into the vast majority of physicians' armamentariums to lower LDL cholesterol. There's no way we're going to get population-level LDL cholesterol control unless everybody is using all of the tools that they have available to them. We even looked at this in our own backyard. Where I am at UT Southwestern, our scientists played a key role in the development of PCSK9 inhibitors. It's a proud legacy of us that Brown and Goldstein, who discovered the LDL receptor, actually came from UT Southwestern. And yet, when we look at patients with coronary disease, followed by cardiology at UT Southwestern, there's huge variability in the uptake of PCSK9 inhibitor use amongst our own cardiologists. In fact, about half of our cardiologists had fewer than 15% of their patients on a PCSK9 inhibitor, and some had actually never even prescribed one. This is really disappointing because these drugs had the potential to really get all of our patients to goal. And it's not like patients don't want to take things to help lower their cardiovascular risk. In fact, they're willing to. And if we look at other medications, we find that 12% of individuals with ASCVD are taking fish oil, which, for the record, has never been shown that supplement versions of fish oil prevent cardiovascular events in people with ASCVD. So we've got a mismatch between the evidence and the prescriber behavior and what patients are actually taking. So how are we going to improve access to novel therapies? Well, the first is, I think very clearly we need to do a better job at educating our providers and empowering them to use non-statin therapies to help patients get to goal, either for those already on statins or those who are unable or unwilling to take one. We also have to have lower cost therapies because many people with high deductible plans pay a substantial out-of-pocket cost share for their drugs. With sticker prices in the several $1,000s a year range, even with insurance, these remain unaffordable to many. And then finally, there's multiple different options for cholesterol lowering. I've talked about PCSK9 inhibitors, but we also have bempedoic acid, a prescription medication that's available as a pill, that's a non-statin. And we have inclisiran, which is an injectable therapy that's every 6 months once we get patients on drug. The challenge is that depending on what insurance type you have, it's hard to know which one of these drugs is going to be sort of first line in the formulary. And it also dramatically changes what the out-of-pocket cost is. For example, patients with a traditional Medicare plan and a Part D supplement often have a zero out-of-pocket cost for inclisiran. But if they have a Medicare Advantage plan, it's usually cheaper for them to get alirocumab or evolocumab. It's really hard for doctors who are dealing with a lot in clinical practice to be able to know which one of these drugs is going to get covered. And then to take the time to go through the prior auth and just find out that this wasn't the right one is really frustrating and I think is actually disincentivizing people from using these. So we need better support systems to help guide docs at the point of care in choosing therapies that are going to be affordable and accessible. And we also need better systems so that we have clinic nurses and pharmacists that are actually doing patient care instead of filling out prior authorization requests all the time. The future is bright for additional lipid-lowering therapies as well. There's a number of additional therapies in development. Two that I'm most excited about are actually oral versions of PCSK9 inhibitors. Laroprovstat is an oral PCSK9 inhibiting medication that in phase 2 studies dosed as a single once-a-day pill lowered LDL cholesterol by up to 51%. And there's an ongoing cardiovascular outcomes trial now studying this to prevent cardiovascular events in people at risk for CVD or who've already had it. Enlicitide is probably the furthest along in terms of new therapies. This is another oral PCSK9 inhibitor, and when given on top of background statin therapy, lowered LDL cholesterol by 60% compared to placebo. 8 in 10 patients who were given enlicitide on top of their background therapy were able to reach aggressive LDL cholesterol goals. This drug has been granted a priority review by the FDA, and we are optimistic to be able to have this drug as an additional part of our armamentarium, although I should note it's not yet FDA approved. But it shows that we may be able to move past only having injectable options beyond statins and ezetimibe to now having additional oral therapies. And what I'm most excited about is actually the potential for these drugs to be put into combination with the statin. And we estimate that we could get 85 or greater % LDL reduction by combining one of these oral PCSK9 inhibitors with a statin. So now we're starting to overcome the challenges of polypharmacy, where if you have somebody already on a statin, I'm not adding another pill. I'm just going to change it to a different fixed dose combination that will allow you to still take a single pill a day and be much more likely to reach LDL goals. I'm hopeful if these drugs come out and are reasonably priced and have good access by payers, that this is going to help us overcome a lot of the clinical inertia to non-statin use. Now, the guidelines talk not just about lipid-lowering therapies, but there's other new things in the guidelines that also have their own population health challenges. The first is LPA testing. We know that lipoprotein(a) is a potent risk factor for heart disease and a leading cause of premature myocardial infarction and stroke. Between 15 and 20% of US adults have a high lipoprotein(a) level, but only about 3 in 10,000 US adults have ever had their LPA tested. We have a ton of work to do in terms of screening lipoprotein(a) and identifying those individuals at increased risk. It's particularly important as we're developing therapies that may actually lower LPA and help prevent cardiovascular disease events in these individuals. So how are we going to do that? Well, the first is we've got to do a massive public information campaign focused on physicians and advanced practice providers who may not be familiar with LPA. And I think it's unfair for us to ask our colleagues to order a test if they don't know how to tell patients about what it means or what to do in response to it. I think we also have to go beyond the doctor's office in increasing access to screening for not just LPA, but also LDL cholesterol. We know there still remain gaps in the proportion of US adults who have ever had their LDL checked. And we've had remarkable success with workplace screening, outreach in churches, grocery stores, community events, and pharmacies. The Family Heart Foundation also has been conducting a really innovative approach, actually taking LPA testing out of the hands of anyone else and putting it directly into the hands of the patient. CholesterolConnect.org is a website that will bring you to the Family Heart Foundation's program where you can put in your information and they will send you an at-home finger stick that will measure not only your LPA, but also your cholesterol. So you actually get a 2-for-1 screening for familial hypercholesterolemia, which we still have major gaps in, and screening for lipoprotein A. The other tool that we have in our armamentarium for risk assessment is coronary calcium testing. We've now provided very clear guidance in the guidelines based on what your CAC score is, how low your LDL cholesterol should be. CAC testing, I'll also tell you anecdotally as a physician, is perhaps one of the best ways to overcome patient reluctance to initiate lipid-lowering therapy. Somebody who's sort of on the fence about whether or not they should start a statin jumps off of that fence very quickly once they see evidence of cholesterol buildup in their coronary arteries. And for those of you who aren't familiar with CAC testing, it's actually not the calcium that we worry about, but the presence of calcium indicates that somebody has a lot of cholesterol plaque buildup around it. That's the plaque that breaks off and causes myocardial infarctions and strokes if it happens in your brain. But CAC testing also faces its own barriers. First is that we don't use it that much. We're seeing big uptakes, but many patients are still not referred for coronary calcium testing. The second is that the out-of-pocket cost can be high, even in patients who have it covered by insurance. Interestingly, in Texas, where I am, our legislature passed a bill in 2009 that mandated insurance coverage for coronary artery calcium testing, which sounds really great, except that for many of my patients, even if it's covered by insurance, their out-of-pocket cost or their cost share for the test can be $100 or $200. Now, for many people are totally willing to pay that, but a lot of the patients that I take care of, $100 or $200 additional out-of-pocket cost, in addition to the cost of their medications and regular visits, is still cost prohibitive. So we need to do a better job at lowering the cost share or perhaps eliminating any cost share for coronary calcium testing to help people have better access to this. The other most important policy change that I think we need is creating better incentives for population level prevention. And health systems and clinicians are highly responsive to quality measures. CMS quality measures are one of the best ways to motivate health systems to invest in creating health system-wide strategies to address population health challenges. And we physicians have been calling for an LDL cholesterol-based quality measure. We're actually asking to give us a report card to grade us on LDL goal attainment. And National Forum has actually helped support recent initiatives to try to get CMS to implement an LDL cholesterol-based quality measure. Once that measure is in place, health systems will transform to start thinking about what they can do for all of their patients to increase LDL cholesterol goal attainment. So just to summarize, how are we going to implement these guidelines? How do we improve lipid management across the board? Well, we need better clinician support to help implement the guidelines and decrease the cognitive burden and workload that we're asking on our primary care physicians. We need lower cost therapies. We need better access to LPA testing and CAC testing, and we need to take it out of the doctor's office and try to get people where they live, work, and play, not just when they go to the doctor. We need better public education to combat misinformation. And ultimately, we can help drive this with policy incentives to help support population health and LDL cholesterol control. I'm pleased to be working with the National Forum, who's trying to tackle this on a lot of different fronts. And I thank you all for joining us today to help talk about this a little bit more. And with that, I'll stop sharing and turn it back over to John.
Thank you so much, Dr. Navar and Dr. Isiadinso. We appreciate both of you giving us a very clear overview of the new guideline and helping us think through the practical steps that are needed to put the recommendations into action. Emory, I really liked your closing slide there where you showed that no matter where those of us who are listening to you sit, whether we're patient advocates, whether we are clinicians, whether we are decision makers in a healthcare delivery system, whether we're payers, whether we are in public health, whether we're policymakers, there is a role that we can play and that, frankly, we need to play in order to assure that people are able to fully benefit from, as you said, these additional weapons in the cholesterol fighting, LDL cholesterol lipid fighting armamentarium that just keeps getting built out, becomes more robust. But if people don't have access to it, then it doesn't work. So thank you so much for your presentations. Now I want to open the conversation. So please use the Q&A function at the bottom of your Zoom screen to submit questions. Some people have already been doing so, and we appreciate that. We welcome questions about the guideline itself, about implementation challenges, patient communication, clinician education, risk assessment, treatment decisions, access barriers, and opportunities for systems level change. And we also invite you to share examples of how your organization or practice is working to improve lipid management, cardiovascular risk reduction, or patient education. If you'd like to briefly share a best practice or a local initiative, implementation example, please note that in the Q&A box, and we'll try to promote you so that you can speak as time allows. Now, to start our discussion, I want to begin with a few questions. I have one, I'll take that prerogative, and then we have questions from audience members. So, Dr. Navar, you began by saying that if we implemented the guideline for everyone, it would bend the curve on the leading cause of death in the United States, ischemic heart disease. And that paints, at least for me, it paints a really motivating picture in my mind's eye. But the if in your statement is huge. And it's widely accepted that it takes up to 17 years for only 14% of published evidence to translate into practice. The length of time, let's call it what it is, it's a massive systems failure, means that instead of everyone who could benefit from guideline recommended care, millions of people have heart attacks and cardiovascular conditions that limit their independence, their productivity, and their well-being, and that cost everybody billions of dollars to treat, all of which could be prevented by rapid universal uptake of the guideline. Now, we've gathered patient advocates and educators, various types of clinicians, public health professionals, healthcare system decision makers, payers, and purchasers for this briefing. What actions, this is the question, what actions can we stakeholders take this week and this month to hasten the uptake of the guideline and help people benefit from the science-based clinical guidance right away? Now, I realize we can't do everything all at once, so where would you start? What's the highest impact, low-hanging fruit that you would have us pick?
Well, I think there's a few things. For people who are involved in policy, I do believe that an LDL-based performance measure is going to be a carrot that will incentivize people to be a lot more creative around thinking of solutions within healthcare systems. So, that would be, continued advocacy around that is really key. There's sort of local advocacy. I think we shouldn't downplay the need for just better communication with our own channels, our friends, our family, our coworkers about risks of cholesterol, lipoprotein(a) screening, LDL measurement. Go to your workplace, see if you have a workplace screening program. Can you incorporate LPA testing into that? Look at the materials. Is it actually aligned with the guidelines in terms of what's telling people about LDL cholesterol? There's a lot of sort of local things that we can do within our own environments to sort of help spread messages. Somebody here has, and then I think we all have to sort of get creative within our own environments to think of solutions. There's not going to be one thing that we can all do. But Sarah Eve Sarlicker just asked a question. We have connections with community health workers in our state through several channels. Which organizations can translate these guidelines into statements that can be shared in multiple languages? I don't have an answer to that, but I will get one. I know that the Heart Association and the American College of Cardiology are working hard to create patient-facing materials around these. Trying to think about how do we translate them and sort of disseminate those would be great. And so, Sarah Eve, if you can send me an email, I'm happy to help try to connect you with that. But people know their own organizations and their own environments, and I think are going to be able to be much more creative at thinking of solutions and us sort of giving them from the top down. I'm curious what Ijeoma's thoughts would be on that.
Yeah, it's a challenge, and I think we start within our own backyard. In our clinic, we actually have handouts about lipoprotein(a) screening and the importance of cascade screening and the associated cardiovascular risk with elevated lipoprotein(a). And in the language that the National Forum used to develop that document that guides the discussion with patients was incredibly helpful. And so I actually have put it in all of our clinic rooms at Emory. It is a good starting point, and I actually have them take it home so that they can also talk to other family members. Now, their family may be out of state, so I actually tell them to take a snapshot, a picture, and send it to their clinician, but then to also encourage the family members to make sure that they're asking their clinician to get tested and why it is important. I think beyond that, then we need to empower clinicians to do the testing and encourage to follow up with testing. I think one thing is that once we test, we need to ensure that we're acting on it. But then also our patients are finding out what their test results are. So just like blood pressure, I'll have my patients when they tell me that they went to see their primary care physician or the APP, I ask them, well, what was your blood pressure? It's the same thing if you went to see your clinician. What was your LDL cholesterol? Were any changes made to your regimen based on what those results were? Well, let's talk about that, So understand what your goal is. I think empowering everyone that's within the patient treatment plan, including then advocating, as Dr. Navarre said, policymakers to help us move the needle. I think that is where we're going to make a big difference.
I just want to amplify a great comment that was made by Matt Holland at an RDN. Again, a part of this team that we absolutely need to work with our dietitian colleagues from the Orange County Health Department. He says that we work in public health and have a Live Healthy Ocean County program, provides free health screenings in the community, includes lipid panel, glucose, A1C, and blood pressure. So, this is a lipid-focused talk, but we know that there's gaps in screening for all sorts of cardiovascular risk factors. And truly, risk assessment for dyslipidemia requires comprehensive screening, including blood pressure, diabetes screening. And so I love the idea of screening programs that sort of hit multiple risk factors at the same time. And our community organizations are doing just amazing work alongside our clinics that treat the underserved, like FQHCs, who are really critical safety nets and helping identify those patients. And, the thing is, these aren't expensive drugs. Once you get to secondary prevention and an LDL less than 55, yeah. But for primary prevention, statins are like $4 a month. Ezetimibe is available on Mark Cuban's pharmacy without insurance for like $10 for 3 months, something close to that. I don't remember the exact number right now, but these are not expensive drugs, and lipid panels are not expensive either. So prevention is cheap. Treatment of ASCVD is where it gets expensive.
And failure to prevent is expensive.
That's right.
Dr. Isiadinso, Tim Nicolai asks, a health system I consult with is trying to better understand the differences of ASCVD risk versus the prevent calculator and how to integrate it into workflow. Are there any go-to resources or guides that you would suggest?
Yeah, actually, you can go to our ACCHA document, and I think there is a link, if I'm not sure, Emory, is there not on the website somewhere? For
There-
that,
Yeah.
the Prevent ASCVD Risk Calculator. And there is one also. I think if you type prevent ASCVD, I'll try to do that while we're talking, and I think it should pop up. What we have done here is that we have worked with our IT department because we have Epic, and it had the pool cohort equation embedded in the system so that you could just do a dot phrase and you would get the pool cohort equation, the 10-year risk. And so now we are doing that with the prevent risk. So that is a way so that it can be sort of available system-wide. And any clinician who sees a patient can calculate the prevent, using the prevent calculator, assess the 10-year ACPM risk during that visit and inform the patient. And
Yeah,
I'm looking, go ahead.
I'll add on that one too, is the Epic is actually the next Epic release is going to have that auto put in. So for you guys were able to get it done, it sort of bespoke, but the next Epic upgrade is going to have this prepackaged as part of the EHR, and I would be surprised if the other big companies don't have that also sort of auto integrated coming soon.
And I do see
That's
here online, and I'm sorry, John, I was going to say I can put this in the link, the AHA Prevent online calculator. So it's easily accessible. People can save it to their computer, and it may even be on MedCalc by now.
Thank you. Thank you very much. Sarah Eve Sarlicker asked about resources, guides that community health workers can share in multiple languages. The shared decision-making guides that Dr. Isiadinso mentioned and uses in her clinics will be produced in both English and Spanish, and they'll be available next month. So if you've registered for this briefing, which obviously you have since you're here, you will receive those resources. They're free, and I just want to call out quickly. I appreciate, I love hearing that you're using them, EJ. That's fantastic because, as Dr. Coop told us, the best care, the best medicine doesn't work if people don't take it. Same thing with these guides or these tools. But I want to share the credit because they were developed by a collaborative, and they're co-branded by many organizations of which you're part, and many of the organizations who are part of crafting the new guideline. So they're highly credible and very well informed.
I'll put a link in response to Sarah's question too. Heart.org has English and Spanish materials on that are patient facing around cholesterol.
Yes.
So that's another resource.
Yeah, absolutely. Absolutely. So we have a question. It's very specific from Yvonne McHugh, who asked, was the Clearly test, coronary plaque analysis, considered as part of screening, evaluation, and treatment?
So in short, we sort of discussed everything. It turns out that for risk assessment, a plain calcium score, which doesn't require fancy AI, just sort of, it's a low dose, meaning not a lot of radiation, CT scan of the chest, that is with a regular calcium score is really sufficient for the vast majority of patients to get risk assessment. There are several companies that are doing additional analysis of scans where we actually give patients contrast and use more radiation to look at the plaque specifically. But that's not a screening test for prevention. It's expensive. There's more radiation. And so that's still sort of an emerging technology for a smaller group of individuals. So the nice thing is there's a lot of places that will do a coronary calcium test for less than $100 and doesn't need the additional AI or other things in order to really get robust information. But this is a field that's exploding. There's a number of trials going on now to try to learn, are there other ways of us to measure and quantify plaque using computer-aided algorithms like Clearly's. And I suspect in the next 5 to 10 years, our updated guidelines are going to have a lot more guidance on how to integrate those. But I think right now, short answer is not ready for prime time.
Okay, thank you. Well, we're down to our last 30 seconds. Unfortunately, Emory, Jen Childress has a question for you. Are the guides to fight misinformation that you referred to, are those for statins specifically, and are they publicly available?
So my favorite guide for misinformation is actually by the Center for Climate Change Communication. It's called the Debunking Handbook from 2020. And it provides evidence-based sort of guidance for how to combat misinformation across any domain. It's very applicable to statins, but it's actually applicable to a lot of other things as well. And it's available as a free PDF. It's not a long read, and I absolutely love it. And so I'll put it in the chat as well for everybody to see.
Thank you.
Yes, it is available.
Thank you. And thanks to everyone who joined us today. A very special thank you to Dr. Isiadinso and Dr. Navarre for sharing their expertise and practical insights. We are honored to have two giants in preventive cardiology with us today and presenting this briefing. Thank you. Before we conclude, we're going to ask you to participate again. So remember the question at the beginning. Here's the poll on screen. Please take a few seconds to answer the poll.
All right, closing the poll in about 5 seconds. And here are the results.
Hey, EJ, Anne-Marie, you moved the needle. You raised the level of knowledge and understanding. So congratulations. Thank you again. Great job. One of the challenges with any new clinical guideline is moving from publication to awareness and then from awareness to routine use. And I was reminded of that earlier this week in a conversation about the time it takes for the evidence-based practices and guidelines to be widely adopted. That conversation was with the National Forum's chair, Dr. Bern Melnick, who shared that when she asked large audiences of nurses last week how many had read or were familiar with the 2025 high blood pressure management guideline, only about 15 to 20% raised their hands. Now, those guidelines have been out for almost 10 months now. And that's not a criticism of clinicians. It's a reminder that dissemination and implementation are hard. They take strategy and tactics, and even strong evidence-based guidelines do not improve care simply by being published. They have to be understood, communicated, adopted, and built into practice, which is why today's briefing is so important. The dyslipidemia guideline was just released in March. And by being here today, you are on the leading edge of understanding it and helping move it from paper to practice. So here are a few quick takeaways. First, the 2026 guideline highlights the importance of early evaluation and treatment. Dr. Isiadinso said as early as age 2. Second, the guideline brings back specific LDL-C targets, which were absent from the 2018 guideline. Third, it adds a strong recommendation of LPA testing for every adult, and at presently only 3 in 10,000 have been tested. Fourth, the guideline elevates imaging to measure risk, with CAC scoring serving as a decision aid when treatment decisions are borderline or uncertain. And Dr. Navarre pointed out how it's also very motivating for patients. And as Dr. Navarre said, we need to fight misinformation about statins. The spreaders of disinformation are active. We must be active too to get the facts to the public, patients, opinion leaders, and policymakers. But the change, the bending of the curve, begins with us. 80% of people not on statins said they were never offered one. Remember that slide? Clinicians can fix that problem without changing anyone else's behavior. And pharmacists are really good at getting people on appropriate medications. They strengthen team-based care. But they can't play that role where policies keep them from being paid for doing so. So we need to change policies to unshackle pharmacists. Both Doctors Isiadinso and Navarre explicitly highlighted the importance of treatment adherence. Currently, most patients with ASCVD fail to achieve recommended LDL-C levels, and contributing to that unfortunate fact is another fact. Most patients with ASCVD do not adhere to their lipid-lowering therapy regimen. Implementation matters. Improving cardiovascular health will take more than awareness of the guideline. It will require clear patient communication, team-based care, shared decision-making, and better access to testing and treatment, community and employer-based outreach, and policymakers that support guideline adoption. The Value and Access Collaborative is working to support continued education and collaboration beyond today's briefing. Please watch your inbox for the updated shared decision-making tools. They work. A Mayo Clinic trial found that using them increased patient engagement by 50%. Improving lipid control for people throughout the United States will be a team effort. So please use the knowledge and the resources shared today. You said you gained knowledge today. Please use it to continue the conversation within your organizations. Lead those conversations and consider how these recommendations can be put into practice in your setting. Now, a favor that I'm asking of you, please take a moment to complete the brief survey link that's linked in the chat. Your feedback is invaluable and helps us shape future programs. Thanks again to Drs. Isiadinso and Navarre. Thanks to the National Forum's Value and Access Collaborative partners, Ardelyx, AstraZeneca, Bristol-Myers Squibb, Pfizer, Novartis, and Regeneron. Those sponsors' support helps make these educational briefings and implementation-focused discussions possible. And I think you know that briefings like this don't just happen. I want to thank National Forum team members Julie Harville, Whit Weber, John Bartkus, and Jen Childress for doing all the heavy lifting to organize and produce this briefing. Thank you again for joining. Appreciate your commitment to advancing cardiovascular health and prevention. Now, let's go make the world healthier.